I'm Satchit Balsari. I'm an emergency physician and associate professor at Harvard Medical School and the Public Health School. I've studied disasters and humanitarian response for over 20 years, and along with colleagues here, I co-direct CrisisReady, which is a collaboration between the Harvard Data Science Initiative and Direct Relief. We provide data-driven decision support during crises. Hurricanes affect health in myriad ways. There are, of course, the direct impacts of hurricanes that we can all imagine and are familiar with. Wind speeds will cause damage, things will fall over you, you might get trauma from the wind due to the hurricane. Floods are a big problem with hurricanes. Drowning is not uncommon, electrocution from downed wires. But what is more important and what is often sort of not in the public eye is the persistent morbidity and mortality that is caused by these kinds of natural disasters. It is not just the here and now. In the US, for the most part, we're quite protected just because of the strength of our built environment from the direct impact of natural disasters, from the direct impact of hurricanes. But it is the indirect impact. You are forced to move out of your home. You've missed your doctor's appointment. You've lost power, and so you cannot refrigerate your insulin. You cannot use your nebulizer. You cannot get to your dialysis. You miss your chemotherapy appointment. And it is sort of that long-term impact that can persist for weeks or even months, depending on where you live, that really results in prolonged suffering from these kinds of disasters. A good example is Hurricane Maria, where though the official death count was 64, our team that surveyed over 3,000 households in Puerto Rico found that the death count was closer to 4,000. And it wasn't the day off or the week off, but it was that excess mortality, the number of people that died in excess of what you would have otherwise expected for that time of the year, touched 3,000, 4,000 over the next few months because of these disruptions in healthcare access, because of disruption of wages, because of a lack of access to critical utilities. At CrisisReady, what we have been able to do is study near real-time population mobility data. This builds off Professor Caroline Buckey's work, built on signals from cell phones, either cell phone tower data or GPS signals from social media. At CrisisReady, we use data from Meta's Data for Good program. So it is essentially aggregated, anonymized data from people that use Facebook on their cell phones. We've been using this data for the last several years and have responded to about 40 or 50 global crises. And the CrisisReady data for Milton have been really interesting. We found foremost that evacuation orders worked. Evacuation was very effective, as we've seen in the news, in Zone A. But what our data also revealed is people went largely from Zone A and Zone B to Zone C, D, and E. So they were still evacuation zones, but because they were not under mandatory evacuation then, people didn't travel very far. And they may have gotten lucky this time, but it is worth looking at this more closely to see whether evacuation messaging can be even bettered or done differently, or whether the decisions that people made about where they should evacuate were indeed sound decisions. To date, most health systems in the United States prepare for disasters largely by preparing for mass casualty incidents. And we really need to reimagine how we think about disasters and their impact of populations in the United States and elsewhere. We prepare for 100 people showing up to the hospital and quickly triaging them so that they get good, appropriate care in a very brief amount of time. Unfortunately, that is not the only thing that happens, or sometimes not even what happens. What happens instead is that entire counties might lose power. People will be forced out of their homes, but even healthcare facilities have to be evacuated. So there are two elements of disaster response after disasters that we really need to do a better job at. We need to prepare for health system evacuations, which most hospitals do not want to think about, and doing it in a way in which it is safe. These are complex issues with electronic medical records, with the folks that would still be in a hospital when there is a major disaster. Those would not be the least sick, but the most sick, that we really worried about transporting out in advance. And so how do you take these critical care patients with their IVs and their drips, and where do you send them to? Do the receiving hospitals have capacity to? What I'd really like to see is that when hospitals or cities are doing tabletop exercises and preparing for simulations, that they actually prepare for scenarios where entire health systems or hospitals have to be evacuated, and think about what that receiving load on the health system tends to be. In Hurricane Sandy, when hospitals were shut downtown, those of us working uptown, we continued to see a surge in our inpatient visits, in our outpatient numbers, in our ER, not for weeks or months, but for years, until the hospitals downtown fully recovered and had the capacity to deal with this. And this is one of the wealthiest corners in the United States. The other thing we're not thinking about is just people at home. After disasters, they lose power, or they're unable to access their pharmacy, or unable to get to their healthcare facilities. In some cases, like Katrina, Maria, the healthcare facility itself is damaged. Think about how hard it is just to get a regular appointment with primary care. Now imagine the disruption when there is a hurricane or a snowstorm and you miss that appointment that you had been waiting for 6 months, or you're unable to refrigerate your medications, you're unable to plug your nebulizers. All of that creates this prolonged morbidity that can be and should be avoided with the data we have. We know where the vulnerable are, we know where they're moving, we know where power infrastructure is breaking down. These data are not easily available to our health systems and to our emergency responders. And that's what we're trying to do at CrisisReady. We're trying to make these data available in near real time to response agencies. What really needs to be done is to build this into our preparedness culture, into our simulation exercises. Departments of health should have access to where our most vulnerable are. There is a list called the Empowered Dataset in the United States that is maintained by HHS, which, when a disaster is declared, is made available to local officials, where you essentially know where everyone on durable medical equipment is, which means, folks that require electricity for running their medical equipment. These lists are hard to use because they are not preemptively available to county officials always until a disaster is declared. There's an interesting tension here because individuals want their privacy. They do not want necessarily government officials to know what their medical issues are. But at the same time, in disasters, you want to know where our most vulnerable patients are so that you can preemptively protect them. Why can't health systems more proactively build a little redundancy into their schedule so that missed appointments can be addressed very quickly after these kinds of disasters? This is going to take time. It's going to be sequential. We're seeing small shifts in how we're doing this in the United States already. With the wildfires in California, the California Department of Public Health has been very proactively engaged in working with communities, vulnerable communities, with populations with access and functional needs. We also saw that with the mandatory evacuations in Milton, where at least early data seemed to suggest that people in Zone A did follow the orders. Our data shows that about 45 or 50% did. It'll be interesting to see who these other 50% were that they didn't and whether they were out of harm's way. But that kind of proactive engagement with our population will play high dividends in ameliorating the suffering that follows these disasters weeks to months after the disaster strikes. There are really interesting data out there from remote sensing, from satellites, from our cell phones that can provide decision makers during crises very useful information about who the vulnerable are, where they're moving, where there is capacity to receive them, where infrastructure is not damaged. With where power of computing is headed and with where machine learning is headed, we will see some really interesting publicly available data sets. Google launched wildfire parameters last year. There is interesting work being done to assess building damage after disasters. And yet, on the other hand, basic information like live bed capacity at the hospital level or at the healthcare facility level is still not readily available. Even during the pandemic, where hospitals were sharing bed capacity data. Most places did this manually, and this really ought to be an automated process. There should be a dashboard available where this information is live with a break glass scenario during disasters. So even if hospitals are not comfortable sharing their bed capacity data in peacetime, during a disaster, there ought to be regulation that requires them to make this available in real time. Disaster medicine used to be a little peripheral to the education process in the hospital. Just some of us that would be interested in it would be educated in disaster medicine. But given the increasing frequency, intensity, severity of natural disasters because of the changing climate, I will not be surprised if disaster medicine education and preparedness will get more mainstreamed into medical education.